Everyone, this is a video about true medical diagnoses, the study of processes and considerations behind the making of medical diagnoses. So, who am I? So, my name is Louis-Philippe Ewert. I'm a nurse practitioner in Ontario, Canada. And why am I making this video? Is really to reflect on the often forgotten mind gymnastics that we as clinicians use basically to arrive at medical conclusions for our patients. And so, in studying to become a nurse practitioner, I found that there was an extensive amount of time spent on presenting us with diseases, symptoms, clinical presentations, what exams to prescribe. But I found there was not enough time spent on actually learning how we arrive at medical diagnosis, cognitively speaking, really. And so this is not a fault of the program per se, because there's so much critical information to cover, really, that this would be another thing on top. But I find that how can we evaluate our own diagnostic abilities if we don't really understand what's going on, mentally speaking? What are the mental, philosophical consideration and cognitive processes that underlie a medical diagnosis, really? And so I'm not an expert on the subject, but I decided to make this course to sort of teach myself and share it with others like you. And so some of the information presented here can even be applied to other fields that use diagnostics, like car mechanics or construction or even computers. And so making a diagnosis is really arriving at a conclusion. Sometimes it's a temporary conclusion, sometimes it's a definitive one, hopefully. And like in any applied field, whether it's business, engineering, or medicine, if you reach the wrong conclusions, it can have dire consequences, right? So I do love this topic. I hope that many will enjoy this little journey into medical diagnosis with me. And I hope that I will aid some clinicians in reflecting on their own diagnostic skills. A few disclaimers. So this is not part of any school or work or organizational project. I did this on my own free time, and I have no conflict of interest in the information I present here. This information is free, and it's also open access under the Creative Commons attribution license. So you can use this, distribute it, reproduce it, just as long as you cite the work correctly. And I really welcome any further addition to this discussion via comments or personal messages or yeah, really. And sorry about that. I will try to make a paper version of this video available through a public sharing platform, hopefully in the near future. So here's the outline of what we're going to be covering. Essentially, the first step is to talk about the philosophical foundations and what is the importance of philosophy in diagnostics. The second step is going to be cognitive foundations. So what are the mental processes that we are using when we're making a diagnosis? Third topic will be shortly about the degrees of precision when we're making a diagnosis. The fourth will be about the different sources of information and tools we can use to arrive to a diagnosis. The fifth one will be about the barriers into making a diagnosis. Sixth one will be the different types of medical diagnosis that exist. And finally, we're going to talk a bit about artificial intelligence. And so here we go. The first step really is to ask ourselves, what is a medical diagnosis? So according to the Center for Disease Control in the US, diagnosing is the act of or process of identifying or determining the nature and cause of a disease or injury through the evaluation of a patient. So basically, we as clinicians are trying to be as objective and as truthful as possible when we're describing the state of health and disease of a patient. So when we're talking about some of the philosophical foundations, the first thing that came to my mind is really the importance of truth in diagnostics. So if medical diagnosis is a search for truth, then what is truth in medicine? Or what is truth in general? And so I dug up a couple of theories about truth and philosophy, or rather the different types of truth that exist in philosophy. And so there are many philosophical approaches to defining what truth is. Epistemology, the theory of knowledge, also is involved in this discussion, but I don't want to go too much into the intricacies, the philosophical intricacies of all of this. I just want to really briefly touch on the different kind of truths that exist in philosophy and how they relate to medicine. So the first really kind of truth is the stems from the correspondence theory. And so in that theory, the statements and beliefs are true if they are aligning with the actual state of things. Now that sounds obvious, but in other words, we're trying to accurately formulate thoughts and communicate them to describe an objective reality. So this touches on the concept that basically there are objective truths that are independent of our beliefs, sort of like eternal or absolute truths, unchanging, timeless, whether we think about them or try to understand them or not. So that's the first kind of truth. The second kind of truth is the coherence theory truth. So in that theory, the statements and beliefs are true if they are coherent within a system of other truths and beliefs. So you cannot find a truth alone. A true truth is really sort of melded with other truths. The third kind of theory is the pragmatic theory, which states that basically anything is true if it proves to be useful or has practical consequences for us. The constructivist theory is the statements and belief that at all times, a truth is a result of social, cultural, and individual mental constructs. And then we have the relativist theory, which states that statements and beliefs are true for some but not all, depending on their context and perspectives. So this touches on the subject of subjective truths that are always dependent on human experience and the angle of examination and beliefs. And then we have the moral theory, which is the statements and beliefs are right or wrong, depending on the ethical framework we are using. And I think that the scientific theory is also very fundamental here because it's sort of like the the foundation through empirical observations, experiments, to arrive at evidence, and also keeping in mind that evidence changes as we get new information. So now the question is really, that's all great, all these truth theories in philosophy, but how does that relate to medicine and diagnostics? So in essence, what is the so what of truth theories for medical practice? So as I mentioned earlier, we're trying to be as objective as possible when we're trying to describe a true state of health and disease for the patient. So when we're doing this, we're actually using a truth that's very akin to the correspondence theory and the objective truth. However, we must keep in mind that our understanding of the patient's health condition is bound within a greater system or framework. So that for us here, for me rather, it's Western medicine, and that's what I've been taught. And it has its own body of knowledge, and it also relies on many sciences. And so when we're using that, all these frameworks to arrive at medical diagnoses, really, we're reaching for a truth that's more akin to coherence theory. And by the force of things, really, because all the frameworks are built, really, there's also a link to constructivist theory here because all science really is a societal product, and it cannot individualize or compartmentalize science. Really, they all come together, building on each other, right? So that's sort of the constructivist theory here. And I just want to point out that we have to keep in mind that the truth, especially in medicine, is really temporal. It's really defined by time, as we know. In the history of medicine, we had a very different understanding of diagnoses in the past as and what we have today, right? And so it's always limited by our current knowledge of medicine and also our understanding of the human body, and also limited by the other sciences and technological tools that basically allow us to analyze the human body. I think also that truth in medicine is really heavily biased by our society's views and trends on health and medicine. So there's many trends with social media right now, and in a sense, there's a lot of people convinced of their different, very varying truths, right? And so that can be challenging to navigate this environment, uh, Western medicine, and also everybody has sort of their own truths now with social media that they can share. Now, whether that's the objective truth or not, but I think that's interesting to discuss here. Really, I think truth is really, that's why it's a foundational piece of medical diagnosis, really. The last thing I want to say about the coherence theory here is that we must obviously remain open to changes in medical practices because our understanding of the body and medicine evolves constantly. So, talking a bit about the pragmatic theory, we're always striving to improve the patient's condition and health when we're reaching for a diagnostic, right? We're not purely reaching a diagnosis for fun of it or for the mental challenge, but really we're trying to, at the end of the day, improve the patient's condition. So this is the part of the pragmatic theory of truth. But as we're doing this, we're also building general knowledge in medicine. Um, Regarding the relativist or moral truths, when it comes to medical diagnosis, personally, I think that even if we take into consideration wishes and beliefs of the patient, it doesn't play that much into medical diagnosis itself because we're reaching more towards objective correspondence, coherence theories, truths. But the moral truths or relativist truths definitely come into play when we're making medical decisions, life or death decisions, respecting the patient's beliefs and all that. I also want to mention regarding relativist theory that, like I said before, I am operating in a Western medicine framework, right? But there's obviously other medical systems that exist in the world, whether it's the Chinese views, the Indian medical views. And so, if we were to look at a patient's condition, perhaps their diagnosis or what explains their problems could be explained in different ways from across the world, right? So, is the truth singular? Is the truth plural? And so it depends kind of how many frameworks we use to see the patient, right? The angle of a view of the patient. As far as Western medicine, I think that truth is basically singular or maybe binary, and that basically means that a patient has or has not a condition according to the list of Western medicine diagnosis, right? So in summary, for this portion, I just want to say that basically there are many types of truths, even in Western medicine, and there's a overall a higher reliance or heavier reliance on correspondence and coherence theories when we're practicing Western medicines. Okay. Now I want to move on to um, we talked about truths in philosophy. We talked about the different kinds of theories and how they apply to medical knowledge. So, how can we be sure that a diagnosis is true, really? What's the process here? And so when I think about it, I think there's really three steps, a very simple process. But the first one would be to be aware of how many differential diagnoses for a given patient complaint or sign exist. And if I looked up on a website called Malacards, and Malacards basically lists, can you imagine, 22,692 medical disorders known to man, including all the subdiseases, genetically unique diseases, very rare diseases, um, subforms of diseases. So that's a huge number. But thankfully, when we're doing day-to-day medicine, depending on your specialty of practice, we're going to be dealing with a more limited pool of diagnoses, right? But I think it's important to keep in mind that there's such a thing as a definitive list of possibilities in in medicine, and again, keeping in mind that this is a temporal list, right? So it changes over time. So the second step really is to be making a choice from this huge list, right? Uh, so the choice is important, and it has to meet certain criteria. I think the first criteria is that the choice has to be able to explain the patient's conditions and be consistent with the signs and symptoms. The second thing is that it has to establish a form of causality of the condition. And the third thing I would say is ideally it should be verifiable with further diagnostic testing. Now, all these three steps should also be evidence based, meaning that they've been studied, they've been journaled, uh, discussed about, peer reviewed. And so when we're meeting these four criteria, we can safely make a selection of diagnosis. But there's also another step here is that when we're making a selection, it implies that we as diagnosticians, have enough information to make that selection, and that we are doing so in a high confidence manner, right? And so diagnostic accuracy can be defined by how often we find the truth. In other words, how often we land on the correct diagnosis. So diagnostic accuracy is also a concept that is quite important in medicine, right? And here I want to talk a bit about comparing diagnostic accuracy between patient self-diagnoses, trained clinicians, and machine language models that are coming up. And so this is a very complex topic because there's so many variables and factors that come into play when we're measuring accuracy and different contexts and all that. But really, in a sense, what is the point of training somebody to become really good at diagnosing and treating, right? Versus a patient. I think with the internet today, it's really more. It's easier. It's more reachable for patients to look at a bunch of information and come up with their own diagnosis. And I think many times they will be right, and many times they do not have all the information needed or have the thinking strategies to uh, basically come up at other diagnoses and possibilities, right? So I pulled up a couple studies comparing diagnostic accuracy, but really there's a lot of studies on this subject, and what I'm essentially presenting here is just a fraction of what's out there. So uh, just keep this in mind. But I found it interesting that in a study from 2023 by Fraser and al., and by the way, all the references are listed at the end of my presentation. So Fraser and all in 23 found that a patient's self-diagnostic skills using Google search and online symptom checkers always scored lower than a real physician in reaching a correct diagnosis. So that's one thing. In 24, a study by Go and al. Found that machine language models such as ChatGPT or Gemini always scored better than human physicians in diagnostic reasoning. In, in 2008, a study by Berner and Graber found that the diagnostic error margins of real physicians was lower in the perceptual specialties such as radiology, pathology, dermatology, and higher in clinical fields. So obviously, when we're looking at radiology and pathology and dermatology, it's a bit more. First of all, it's more visual, right? You have really something to work with, concrete, as opposed to fields such as psychiatry, for example, where the diagnostic boundaries can be a bit more less clear, and really, I think psychiatry is a good example of the opposing spectrum of the perceptive fields, right? So that study found that the error margins was lower when we were dealing with perceptual specialties. In 2019, a study by Barnett and al. Found that diagnostic accuracy was about 63% for individual physicians and increased to 87% when multiple physicians looked at the same case. So I find it interesting here in summary that trained clinicians seem to be better at arriving at correct diagnosis than patient self-diagnosis, which is sort of comforting in a way that we're not studying for nothing. But it also states that machine language models are becoming actually better than human trained clinicians at doing what they're doing. And when you put, I also find it interesting that when you put multiple physicians on a single case, you arrive at a better result. Which is, again, talking about language model is essentially what they're doing when they're doing big data integration. So that's interesting. So again, there's a wide variety of numbers that are circulating regarding diagnostic accuracy of physicians, ranging from, I've seen 30% to 70%, up to 90%, depending on the clinical context, which is very important when we're trying to assess accuracy, really. But we have to remember that there's a varying degree of difficulty in diagnoses, first of all. So simple conditions can be diagnosed easily by patients and physicians alike. Sometimes a simple dermatitis, the patient can self-diagnose as eczema and will possibly write, skin conditions, again, perceptual field it's much easier for patients and physicians alike to diagnose. More complex conditions will usually favor trained clinicians and language models, and that seems obvious, right? I think also that until language models become fully integrated into some form of Android model where there's a perception as well involved, there's a whole side that these language models are missing. That's the nonverbal cues, the intuition, right, of the clinician. And also, like I said, really, diagnostic accuracy cannot be really compared between the different medical contexts where you're going to see a patient, because if you're seeing a patient in telemedicine over the phone, over virtual care versus office medicine, if you're seeing them in the emergency versus primary care or specialist office, they all offer a different level of expertise and time allocated to the patient, right? So that will obviously impact accuracy a lot. So I think that in general, comparing the level of accuracy of these three, patients, trained clinician, machine language models is basically practically impossible. However, I think the most important thing here is that we as trained clinicians should always be striving for diagnostic excellence, really, and that's the best we can do. Here I'm going to be talking about two sort of related subjects and one final thought about the philosophical foundations of diagnosis, right? I think that we can view patients as truth seekers. So they want to know what ails them. Also, a definitive diagnosis can be reassuring to a patient because it basically lifts the veil of uncertainty and all the fear that comes with it. and also provide you the patient clarity on what should be their next step, right, to remedy the situation. So I think patients are really the primary truth seekers. I also think that clinicians are truth seekers, and they are also a truth guide to the patient. And so I think the patients come into to the clinician and they're seeking guidance to find what they have, right? But I think that this comes with the responsibilities for the clinician. So some of the duties as a truth guide would be, first of all, to find what ails the patient in a truthful manner. So always keeping in mind that you're trying to reach for the truth, right? The second thing is we have to make sure we're not overlooking or dismissing cues that the patient provide, and that ties in that we have to not miss red flags and can't miss diagnoses when we're triaging patients appropriately, because this can have devastating consequences, obviously. The last duty I would think is to be as exhaustive as possible when considering potential diagnoses, and so that means including low probability disorders as well. So we're guiding this patient through our process with our own medical knowledge and medical training, but there's always a risk of making too many assumptions, right? And this can lead to a premature closure of the diagnosis that will lead us away from the objective truth. I think there's a sense of satisfaction and pride when we're trying to shed light on finding a patient's problem. I know that for me, it's one of the more enjoyable aspects of medicine, in my opinion, that is sort of like playing detective. I think sometimes the diagnosis is not obvious. Sometimes we're confounded and don't really know what's going on. And also, sometimes the truth can be crystallized pretty fast, and sometimes the truth is sort of tentative while we're gaining further information, right? So the patient will usually the patients accept an initial level of diagnostic uncertainty by the clinician, and they will work with the clinician as a partner to discover that the diagnosis. However, the longer the diagnostic process lasts, the more there's a chance the patient loses faith in the clinician or the system, the medical system as a whole, right? So I think that's where it's important to do this in while keeping in mind the duties I mentioned earlier about being a truth guide, right? And so we can reassure the patient along the way when we are not missing red flags and can't miss diagnoses, and we're looking at all the possible diagnoses for the patient. That's very reassuring for them. Also, the last step regarding truth is that essentially diagnoses are important, and it's important that they are true because they will direct treatment, right? So diagnoses are useful only if we do something with them. And so when we have a true diagnostic and high accuracy, high confidence, then we can apply the corresponding recipe that will take care of the problem, right? Some of the recipes are very limited and small, some are more large and more extensive, involving pharmaceutical, non-pharmaceutical, but they can also be ineffective, they can be partially or completely effective, they can be supportive in nature, they can be palliative in nature. But really, I think that the importance of a true diagnostic is in matching the corresponding treatments to help the patient. So that was the first portion regarding philosophical foundations in medical diagnoses. Now we're going to move on to the cognitive processes or cognitive foundations that we are using when we're making a medical diagnosis. So as I mentioned earlier, making a medical diagnosis is the act or process of identifying or determining the nature and cause of a disease injury through evaluation of a patient. So when we're talking about reaching a conclusion. A diagnosis is a conclusion. A conclusion is also an inference. So what is an inference, right? So according to Merriam-Webster, an inference is a conclusion or opinion that is formed because of known facts or evidence. In other words, we are using reasoning to come to a conclusion that is true. So I dug up what are some of the types of reasoning that are found, and I'm quoting here LibreText. It's a mathematics website, but I found their description of the different types of reasoning pretty good. And so the first one is the inductive reasoning. Inductive reasoning is when we're making generalizations based on specific observations and patterns. So it's used to infer general rules from limited data, and it's used to formulate hypotheses based on observed patterns. So for example, if all the patients with an ankle sprain will present with swelling, therefore ankle sprain cause swelling. That's an example of inductive reasoning. So generally, inductive reasoning is more useful when we're documenting, teaching disease than actually making diagnoses with patients. But it can really be used to make observation across many cases that will lead to general conclusions or theories in the medicine, really. It does, however, instill a fundamental pattern recognition and critical thinking in the clinician. So inductive reasoning is important. The second type of reasoning is deductive reasoning. That type of reasoning involves starting with a set of premises or known facts, and we're using logical principles to reach conclusions. So for example, if tissue damage, inflammation, and fluid accumulation cause edema, an ankle sprain is a form of tissue damage and inflammation, therefore ankle sprain causes edema. So this can be used to confirm a diagnosis. For example, if a patient has a condition X that shows a symptom Y, and the patient shows a symptom Y, then they have a condition X. Again, more used in the teaching, documentations about medicine, medical knowledge in general, but also used when making diagnoses using medical knowledge that we possess. I think the most important type of reasoning that we use as clinicians is the abductive reasoning. So this seeks to find the simplest and most likely explanation for a set of observations, right? So it involves forming hypotheses to explain what we're seeing and testing these to see if they are holding true. So it's the most used type of reasoning when we're doing detective work, scientific inquiry, problem solving, and so it's the main type of reasoning that we use when we are making medical diagnoses. So an example of this would be if a patient has a squeezing chest pain with diaphoresis and nausea and shortness of breath, and we're thinking this is most likely looking like a myocardial infarction or heart attack, but we're going to be doing an EKG and troponin levels to confirm that. So it's a critical type of reasoning that we use to rule in, rule out in medicine. And the last type of reasoning we use is analogical reasoning. So this involves identifying similarities between two things that are similar, obviously, and draw conclusions and make predictions from that. So it's based on the idea that two things are similar in some respects, that if they are similar in some respects, that they will likely be similar in other respects as well. So as we study diseases, we're going to be grouping them in different families and body systems and causes and similar presentations. And this can help us make informed guesses about what is going on really. For example, all the fractures usually will present with some form of pain, edema, limited range of motion, bruising, deformity. And so that helps us identify rather quickly a fracture. Also, we're using this analogical reasoning when we're drawing from medical experience. Also, I would say that analogical reasoning is used in in treatments. Certain treatments, for example, all musculoskeletal injuries usually are using the Price model to treat patients. So protect, rest, ice, compress, and elevate. This is a form of analogical reasoning. Okay, so the next step is I want to talk about 4 different reasoning models that we use additionally on top of the types of reasonings. So reasoning models are a formatted way of applying logic, and they are crucial in making diagnoses. So the first model is really, I would say, is the more straightforward in a way, is the algorithmic decision tree. And so basically what that is, it's a network of relationships between concepts, signs, symptoms, biomarkers of disease. And then we're using clinical decision making to trace an optimal pathway to the most likely diagnosis using the tree, right? So it's branching, and if something happens or is not, something is present or is not present, then we're choosing one branch or the other. So these decision trees rely obviously on evidence-based medicine, and I think they provide really a comforting or robust base for clinicians to rely on when making diagnoses. Now, the second type of reasoning is the Bayesian statistics and probabilities, and they are crucial in diagnostics because they are the basis of the rule-in, rule-out process, really. The Bayesian model is very akin to the abductive type of reasoning, in that as new information comes to light, it eliminates possible diagnoses and narrows down others. So it's in that type of reasoning, the diagnostic process is a continuously iterative process where the clinician is constantly trying to update the pre and post test probabilities that the patient has or has not the diagnosis, right? Pattern recognition and heuristics is another form of reasoning. They are much more fast and sort of instinctual in a way, in that they are mental shortcuts that we use. So we use these cognitive shortcuts when we recognize diseases studied in textbooks as they present in the office and instantly recognize the disease, right? Or when we are using our prior clinical experience with similar cases to diagnose a patient. So that's for pattern recognition and heuristics. And the dual process theory is really a combination of Bayesian statistics and probabilities and pattern recognition and heuristics. And this theory basically states that there's basically 2 ways on how we make decisions. The first is very fast and effortless and based on heuristics and pattern recognition, whereas the second type of decision making is more of a slower, more methodical, and based on more thorough evaluation and more akin to abductive reasoning and Bayesian probabilities. Okay, so we covered the types of reasonings that we use, some reasoning models. And I want to talk a bit about some of the cognitive competencies that we need to have as clinicians. So this is not an exclusive list, right, that I put there, but I think at the center of it is really able to work as a team with patients and other healthcare providers, whether they're radiology technicians or basically any other form of healthcare providers, because we rely on the patients and we rely on the other providers to gain us further clinical data regarding the patient. And so it's important to have a trusting relationship between each other and a professional relationship, right? I think the first step really in terms of competency is to be able to tap into everything that we learned in school, and so medical and scientific knowledge, and also tap into our medical experiences when we're looking at patients, right? The second critical skill, I think, is the ability to manage large quantities of information. So whether it's the patient's medical history, clinical exams data, diagnostic test results, current treatment plans, consultations, and ongoing communication with other providers. There's a lot of information in a chart and with patients as they discuss their problems, and so being able to synthesize and sort of bring all this together is very crucial to be a good diagnostician. There's ways to sort of organize information. And so the nursing process is one of them. For example, it's a 5-step process, right? We start with an assessment, collection of data, then we analyze the data, then we do a planning phase about what we're going to do with the data, then we implement the plan, then we reevaluate the patient and the outcome, right? The SOAP model is also another way of organizing information for a chart, really, but it also helps us in our mind on synthesize information. So SOAP is subjective data, objective data, which is the physical exam, and the assessment and the plan, right? I think a third critical competency we need to have as a diagnostician is to have thinking strategies to make use of all this data in shaping a diagnosis. So thinking strategies, they basically provide us clarity in orienting the diagnosis. And we talked about the algorithm decision trees and the Bayesian probabilities and narrowing down diagnoses based on information progressively. And so these are reasoning models that we can use, or sort of equating to thinking strategies. Another thinking strategy is systematic thinking, right? It's keeping in mind that we have to look at the entire picture rather than isolated parts. And so we cannot just single out one diagnostic exam result and make a diagnosis out of that. We got to look at the whole picture. And the final competency, I think, is to be able to self-reflect on all of this process through critical questioning, really, which is another form of thinking strategy. So critical questioning, basically, we're questioning our own assumptions and cognitive biases when we're making diagnoses. So this is done when we're looking retrospectively at some of our cases to understand what assumptions we made and what ended up being true and false. And I think it's also important to keep an eye on our diagnostic efficiency. So how long it takes us to arrive to a diagnosis, and how often really we are accurate in our practice to become better. So that's these 4 competencies is a solid base. It's not everything that we need. There's more, but this is really a strong base. Okay, I want to talk very briefly about the degrees of precision in making a medical diagnosis, because really there's different. We can look at something with a lens very close or from afar, and it can change things, right? So I'll give an example of an ankle injury. Sorry, an ankle injury, or is basically a complaint that you hurt your ankle. Headache is the same, that your head hurts. That's a very broad, even I would say undiagnosed issue, really. But then we can move into the more broad diagnosis, which would be, okay, we're talking about an ankle sprain, and then we're talking about a tension type or cluster or migraine type headache, right? Then we could even narrow it down a bit further with the ankle sprain, for example, and say, is it a lateral versus medial ankle sprain? Is it a tib-fib ligament complex ankle sprain? And we can also grade it. Is it 1, 2, 3, depending on if there's a complete tear of the ligament, right? And then we can even narrow it further down. Usually that's when we're using diagnostics, imaging, where we are actually trying to specify which ligament is involved. Is it the anterior talofibular ligament? Is it the calcaneofibular? Is it the posterior talofibular? Is it the superior peroneal retinaculum? Is it the inferior peroneal retinaculum sprain? And so, is diagnostic precision always necessary? I think refining diagnosis is only really necessary when it's going to change the treatments. So for example, from the example above, it's definitely important to clarify what kind of ankle injury we're talking about, or headache. But grading a sprain, and grading a sprain is also very useful, but knowing which particular ligaments are involved, unless there's a complete tear, we need a surgery, for example, is not usually useful. And so In other diseases, such as lung cancer, you want to specify is it a small cell lung cancer versus a non-small cell because it will change the treatment. So this is obvious. It's quite obvious to most clinicians, but we have to keep a certain, um, I guess it ties in with the concept of efficiency, right? So as we're ordering more diagnosis, as long as we have a working diagnosis and we can provide a safe treatment, and that will resolve the problem, and then we don't need to dig really further down, is what I'm trying to say. Okay, that being said, I just, all right, so we're going to be talking about the sources of information to make a diagnosis, really. I think the first one is to, and so I guess this portion would be probably more interesting to patients than actually trained clinicians, because most of them will actually already know this, but still find it interesting to remind ourselves what are some of the exhaustive sources to use, right? So the first one I think is the epidemiologic trends that we're facing. So I'm talking about disease prevalence and the patient's time and location. It's important to keep in mind when we're seeing a patient, because it will affect different, will affect basically risk for disease and all that, right? The second obvious source of information is the patient medical history. Really, the first step is the ethnic background, the culture, the age, the gender. Yeah, they can all affect disease risks. In nursing, we use the OPQRSTU model to probe more information about symptom, really. And I think there's a misconception that we can only use this for pain, but really you can use this model for pretty much any symptom. So this OPQRSTU means onset, provoke, palliate, quality, quantity of the symptom, what region, irradiation, if any, what are the associated symptoms, if there's a timing, and what's the understanding of the patient, right? So I think it's a key analysis formula for any new onset symptom evaluation. Additionally, regarding the understanding portion of the OPQRSTU is that a lot of patients nowadays with internet research their symptoms, and they can suggest to us diagnosis and diagnostic tests to us, which are sometimes very useful. Yeah, so OPQRSTU is a big source of information. The second one is the review of symptoms, systems, sorry. So when we're seeing a patient, we have a brief history now about what their symptom problem is. It's also interesting to ask the patient about different symptoms they're having in multiple organ systems, right? Just to see if there's anything going on there, because the patient sometimes will forget to talk to us about certain things they're feeling or have been noticing, right? So it's hard to come up with a definitive exhaustive list of all the possible human symptoms, but I count approximately 150 possible symptoms across all body systems. Usually, obviously, there's a lot more different kind of possible presentations in the neurological system and the psychiatric system, so ways to describe human behavior and all that. And a full review of systems with a patient is not always necessary. It's usually necessary when we're dealing with more complex medical issues or systemic diseases. But like I said before, there's times when the patient will forget to mention some key symptom in the encounter, and then when we're probing with the review systems, then this can open up new diagnostic possibilities, right? Adversely, it can also lead us on a tangent when when the patient reveals other symptoms that might or might not be related to the current problem, and this sort of confounds us. So we got to make a judicious use of the review systems to remain efficient in our process. Now the next acronym is my own. Some people will use the sample acronym to get further medical history. I like to use the hammers. I came up with this myself. So it's basically, again, we got to use these questions in a judicious way, because you know open up a whole other can of worms with patient with these questions, but they can also be very revealing for the problem at hand, right? And so for me, the hammers acronym first is habits. So sleep, exercise, tobacco use, caffeine use, cannabis use, alcohol use, and any other drugs. Then we have allergies. Then we have antecedents, so personal and past medical diagnoses, and we can make a sort of adapted questions to the current problem at hand regarding their past medical diagnoses. And then we have antecedents surgical, personal past surgeries they had. And we have antecedents familial, so what medical diagnoses have been or medical problems have been occurring in their family. And then we talk about medications, what they're using, any form of contraceptions, any supplements, any natural products. I also like to include in there a motivation to change. Sometimes it's useful to discuss when the patients are dealing with some addictions, or they want to make some they want or need to make some life hygiene changes, such as weight or exercise or what they're eating. And then I like to talk about the environment where they operate in. So their occupation, school, studies, hobbies, living situation, financial situation, recent travel, pets at home. I like then to talk about their relationships. So what's their marital status? What's their family support network? What's their work relationships like? What's their friends support network like? Is there any power of attorney in the picture? Is there any advanced care directives in the picture? Is the person a natural caregiver? These can impact what the patient's going through. And then if necessary, I also talk about sexuality, obviously. So the gender of the patient, their sexual orientation, the number of partners, if they're using protection, if they're planning for pregnancy, if there's a risk of pregnancy, if they have STI prevention practices, if they have had STI in the past, if they're doing any particular sexual practices at risks, there's their history of sexual abuse, what's their pregnancy history, when was their first menstruation, their last menstruation, their menstrual cycle, the irregularity, the output, if they started menopause already. That's the whole sexual portion. And then case by case basis, sometimes I like to talk if they're spiritual or have a religion. And then we move on to the physical exam. The physical exam is ideally a full measurement of all the vital signs, right? So heart rate, respiratory rate, blood pressure, saturation, and temperature, and ideally also a weight, a height, a BMI. I find that oftentimes the physical exam is a composite exam, so this means that we're performing an exam of the body system that's directly impacted by the symptom history of the patient, but also of other systems that could be impacted by it. So for example, if a patient has a headache, then we could do a composite exam of their general appearance, cranium, head, neck, ENT exam, neuro, spine, right? So another key component of the physical exam is really learning key diagnostic maneuvers and signs that can be performed inside the office and that can by themselves reveal disease or diagnosis right there and then in the office in a sort of definitive way. So there's many of them. For example, McMurray or McBurney tests, right? I think the physical exam is often undervalued these days in the encounters, and especially in primary care, in favor of the verbal history. But there's also a greater potential to perform the physical exam incorrectly in a manner that will not reveal anomalies with the patient. And I also think that we brush the physical exam aside in over reliance on diagnostic exams, because most of the time the diagnostic exams will provide the definitive diagnosis anyway. But I think a physical exam can reveal a lot of information about a patient that the patient is not able to convey verbally, and this can really alter our diagnosis. So it is quite key. And I think there should always be a physical exam with a patient, even if it's minimal. And I also think that a regular refresher training or refreshing ourselves regularly on the proper physical exam is encouraged. So another quick point is screeners. So they sort of sit between patient medical history and physical exams, because screeners such as a PHQ-9 or a Framingham risk score can help us orient the diagnosis. So I find they're really important, as well as I try to use screeners as much as possible. And then we can talk about diagnostic exams. So obviously a key source of information in diagnosis. So we got radiological, pathological, and genetic exams now that will usually provide a definitive diagnosis. There's been a huge shift of burden to these specialties, essentially, to provide us with a definitive diagnosis, which is, kind of impressive in a way, because where would we be if these medical specialists would not exist, right? So that's the first diagnostic exams, or all these three specialties, and then we have blood work and laboratory evidence, right? Whether it's microbiologies, cultures, serology, and all that stuff. So sometimes they can be definitive diagnostics, such as when we're dealing with autoantibody titers, like in lupus, or rheumatoid factor rheumatoid arthritis, or PCR tests for infectious disease, or antibody antigen serologies and cultures, and all stuff like that. Oftentimes, though, they're mostly supplementary evidence to our history and physical exam, really. I think also diagnostic exams can definitely be overused, because the patients either ask for them, or because the clinicians want to avoid liability issues in their practice, really. Another important key source of information are clinical practice guidelines. So they really help us to provide clarity and augment our clinical judgment. So I'm talking about, DSM-5 diagnostic criteria in psych, national guidelines such as the Canadian Hypertension Guidelines or Osteoporosis Guidelines, medical specialty association guidelines such as the SOGC menopause guidelines, evidence-based guidelines such as the core, neck, and back tools, or aggregates of information such as UpToDate. Most clinicians would agree that practicing without these is basically impossible these days, and not recommended as well. All right, the last three sources of information, right? The first one is the consultation with medical specialists. So oftentimes we are stumped by the information we've gathered, and the situation exceeds our knowledge, and we need more guidance. That's where we ask for a specialist. And then I also want to point out that obviously, like, we can ask our peers and colleagues, right? Because some have more experience in their practice, and they can really help us out when we're stuck. And the final piece of information is the non-tangible source, right? It's experience, clinical judgment, and intuition, which are really hard to pin down in words and operational terms, really. But they become more important when cases are looking the same but have different diagnoses, or cases are looking different but have the same diagnoses. And so that's really confounding when we go back to types of reasoning. And so we all know the adage that if it looks like a duck and swims like a duck and quacks like a duck, then it's probably a duck. However, there's many times when it's not. and that is where experience, clinical judgment, and intuition will come into play. So they're quite critical as clinicians. All right, I want to talk a bit about the barriers to make a medical diagnosis as well. So the first barrier is obviously resource constraints. In a ideal world, we would have infinite time with each patient to listen and care and empathize and gather all the necessary information. And in reality, we just have so much time to give to one patient, right? So um, limited time in patient encounters and a high patient volume are definitely constraints in our practice. And it's often as frustrating for the clinician as it is for the patient when we don't have enough time to listen to them. Um, Talk about resource constraints. We also have other things to do in our practice, whether it's administration, looking at lab results, doing paperwork for patients, whether for insurance or claims or employer letters or referral letters. So there's a lot of administration time that basically takes us away from seeing patients, right? So that's another time constraint, and also money. So in Canada, healthcare is free, but it's not free at the same time, right? It costs the system something, and so we have to be mindful of the cost of tests we order for our patients, but also our patients might have insurance or not. There's a provincial insurance as well that covers certain things, and certain things are not covered. So that's a big barrier. So another barrier is the patient itself. Oftentimes we know the patient is a poor historian, right? So it either because they lack the health literacy to talk about their problems, or they have difficulty verbalizing a complaint clearly, or they mention vague symptoms without clear prioritization of what the actual problem is, or they have difficulty recalling symptoms in the encounter or in general. And so that's a big barrier in the patient medical history taking. Patient beliefs can be also a barrier where the patient will self-diagnose and will be very sure about these diagnoses, and it's very hard to start from there as a clinician, in my opinion. Sometimes it can be helpful, although, but it can also be a big barrier. Um, Alternative complementary medicine beliefs and self-diagnosis can also be a barrier to Western medicine, anyways. We are trying to learn to work along the alternative medicines, but when it comes to patient understanding of certain of the Western medicine framework, it can be a barrier, right? Um, and so some patients also have distorted personal or I would say even cultural beliefs about human physiology and pathophysiology, again, according to Western medicine frameworks, right? So that can be a barrier. Another big barrier is a patient who lie or a patient who are deniers or denialers. So there are patients that will fear to reveal the truth because they don't want to face the consequences of that. Some patients have hidden agendas. Some some patients will just not collaborate and just have a lack of collaboration in general. Some will never trust a care provider. Um, some will have difficulty accepting that there's no explainable or actual medical problems, as far as we can tell. And there's also patients who also want more diagnostic tests all the time, even though it's not warranted or it will not change the treatment. So this can make the relationship and thus the diagnosis piece of the relationship a bit more difficult. Now, the patient has their own fault, but the clinician can also have their own fault, right? The clinician can also be a major barrier to themselves in diagnosing properly. So, the first thing I would say is nonchalance or cynicisms of a clinician. When you stop caring about your practice and you stop caring about your patient, really, you won't be making the effort necessary to essentially not take things seriously, right? Or not care enough about your own practice. Not staying up to date with medical knowledge is another big piece. As I said earlier, truths in medicine evolve, and so when we're clinging on to old truths or sort of like bad crystallized truths that we sort of ingrained in our practice, but actually not true, it can be very detrimental. And overconfidence is a big barrier also, because overconfidence essentially makes us rely too much on assumptions and cognitive biases, and we stop listening to the patient as well. So that's a huge barrier. General lack of skill as a clinician in either collecting information correctly through history or physical exams, or ordering the wrong diagnostic exams, or misinterpreting tests and exams, or not knowing about certain diseases and diagnoses as a possibility, or ignoring evidence and having anchoring biases are huge barriers. And finally, we are as of today, we're still humans, right? As clinicians, so there's a human factor. We can be facing huge amounts of stress and workload at work or at home, and this can affect our abilities, right? The final two barriers is the disease itself. Some diseases have very atypical clinical presentations in some patients, especially rare diseases, new unknown diseases, and also difficult to measure disorders and medically unexplained symptoms, right? So fibromyalgia, chronic fatigue syndromes can have very vague symptoms in themselves, and can lead us to thinking that there's no actual problem when there is one. Yeah, another thing regarding disease is the overlapping of symptoms that are obscuring the clinical picture, right? So the patient can have multiple medical issues at the same time, and essentially this obscures the picture for each of their issue. And the last big barrier is the diagnostic tests themselves, right? So they're not infallible, they're not bulletproof, and so some diagnostic tests will have errors in processing, will have false positives, false negatives. They also have limited specificity and sensitivity when we order them, and if we don't interpret them correctly, it can be a big barrier to diagnosis. And also diagnostic tests can be very invasive, and so just on that basis, sometimes we do not order the test if it's not meeting the balance of use and the need for the test, right? So these are all the barriers, as far as I can tell, for diagnosing a patient. And now I want to talk two last subjects. One is the type of medical diagnoses. I actually found it interesting as I was learning, as I'm learning to become a nurse practitioner, better nurse practitioner all the time, realizing that there are actually different types of medical diagnoses. And so the first one is really like I mentioned earlier, the three specialties there. There's a diagnosis by pathology, radiology, or genetics. These are essentially me as a primary care provider, basically passing on the diagnostic responsibility to another healthcare provider who will make the definitive diagnosis, right? And so that's definitely one type of diagnosis we can make. It's a diagnosis by pathology, radiology, or genetics, or evidence of these specialties, right? Another diagnosis is a diagnosis by laboratory evidence, right? And so this is where we rule in and out a diagnosis based on lab results. Obviously, again, usually this evidence is always subject to correct interpretation and misinterpretation of the results by us. Okay, diagnosis by clinical presentation is usually is, I would say, one of the bigger or proportionally bigger diagnoses that we make. So this is where we obviously rule in and out something based on signs, symptoms, and physical exams and key physical tests, right? The last three are more interesting in a way. The diagnosis by exclusion is when we have excluded all the red flags and can't miss diagnoses, and we actually ran through a pretty big list of a significant list of diagnoses and decided that the patient is not meeting these diagnoses, and then we end up with diagnoses of exclusion. Some of the examples of that are irritable bowel syndrome or fibromyalgia or chronic fatigue syndrome, right? Diagnosis by treatment is also an interesting one because this is where we initiate a treatment before we establish a diagnostic certainty, and we're using the patient's response to the therapy as a diagnostic test in itself. And so sometimes a diagnosis cannot be found, and as much as this is frustrating for us and the patient, then we can at least alleviate some of the suffering of the patient, right? But like I said, sometimes prescribing a treatment and seeing it being effective can be a revealing sign of a diagnosis. And then the last type of diagnosis, which is ironically not really a diagnosis, it's a lack thereof diagnosis, the NYD, not yet diagnosis, or differential diagnosis, right? So this is the realm of impressions. This is the realm of we're not sure and we're gathering more data until we're sure. And so when we're dealing with one single symptom, it's quite easy to draw an extensive list of differential diagnosis. But when we have an increasing number of symptoms and multiple concurrent symptoms in the patient, multiple physical anomalies, multiple physical exam anomalies, and diagnostic test anomalies, that's where the picture becomes a bit more complicated, especially when all this data is not congruent with each other. And so we were talking about thinking strategies earlier. One of the thinking strategy to sort of orient our search here when we are in the dark for differential diagnosis is sort of asking ourselves through the Vindicate acronym, right? The Vindicate means, is it of vascular origin, infectious origin, neoplastic, degenerative or drugs, iatrogenic, intoxication, congenital, autoimmune, trauma, endocrine, or environmental, right? So this is sort of orienting our search when we're in the dark. So these are the different types of diagnoses we can use in our medical practice. And finally, I want to talk a bit about artificial intelligence as a conclusion to our topic here, because we are at a critical time in artificial intelligence, and there's basically four big components in medicine, as far as I can tell, where AI is changing the game a bit, and that is machine learning. Machine learning is basically, for example, increasing our ability to recognize in radiology and chest x-rays or other radiological exams some subtle patterns that the human eye was not able to pick up before. So we're able to come up with either known diagnoses or new diagnoses based on machine analysis of imaging. So that's a big piece, right? Predictive analytics is also another big piece of AI, because it allows us to analyze a set of data, whether it's a patient health record or patient symptoms, and come up with predict a disease or even a risk of death, and make a diagnosis, right? So this is using so we talked about all the cognitive functions and processes that we are using as human to make up diagnoses. Well, the machine is doing the same in a computer science way, right? In my opinion, it's probably going to be doing a better job than us in a certain way, in predictive analytics anyways. So another big piece here is big data integration, where machines are just able to take vast amounts of health records and medical data and put it all together and draw clearer correlations between patient data and diagnoses, and so strengthening some of these correlations, and that's very huge for medical knowledge in general. And one of the last piece that's actually really helpful for us as clinicians with AI is that they increase our diagnostic capabilities with what we call clinical decision support systems. So they are a form of algorithmic decision models, like we talked earlier, and they basically help us relieve a huge cognitive load from us, because it's sort of a input-output situation, algorithmic tree that it's just a huge help in coming up with diagnoses. And so I foresee a huge reliance on self-learning machine language models, and using that are actually using algorithms and Bayesian networks, and they will probably honestly surpass human capabilities in diagnostic accuracy, I think, at the same time as eliminating some of the human factor barriers that I mentioned earlier. I think until though that we're missing that nonverbal cues, intuition, judgment, clinical experience piece. As machines become more intelligent, though, we could maybe foresee that gap being closed. And so we come to a conclusion on the presentation here. Here are the references on the left that I used. Obviously, there's a lot of literature on the art of diagnosing. Lots of good stuff out there. This was a brief review of myself. And in conclusion, I just want to say a couple of things, right, to summarize what we talked about. Is like I said, I think that arriving at medical diagnosis is a quest for truth, really, is what it is. And we're using many types of truths, many types of reasoning, many types of reasoning models and competencies, cognitive competencies to arrive at accurate diagnosis, right? But we must maintain a critical eye on our practice and our own cognitive processes, because we want to strive for diagnostic excellency for our patients, right? And just as there is an array of sources to help us make a diagnosis, there's just a big array of barriers as well, and we have to navigate that. So just as we strive to make definitive, true diagnoses, we are also sometimes forced to work in the realm of impressions, like I said, and there's different degrees of precisions also to account for in diagnosis, like I said. We have to keep in mind that we can relieve symptoms and suffering of the patient even if we don't have a diagnosis, right? So that's very important. I also, like I said, because diagnosing is an intelligent-based process and function, really, AI is relieving us from a major cognitive load as time passes on, and it's exponentially increasing power will, in my opinion, likely take over humans in the diagnostic, the medical fields. However, like I said, at the moment, diagnosing still remains an art, right? There's some elements of unquantifiable judgment and intuition and nonverbal that goes on in there, and that a machine could probably not pick up yet, right? So as a closing thought, I want to say that just like in medicine, everything has a cause. But life really is shades of gray, right? So humans are complex creatures. It's not always black or white. And sometimes there are multiple causes, concurrent causes to a single problem. And oftentimes patients and clinicians, we're looking for simplicity. We're looking for a single answer, a single cause to the source of a problem. But oftentimes there's many, and we must keep an eye on that when we're practicing diagnosing. So on this, I wish you a healthy 2025. I hope you enjoy the presentation, and you can reach me by comments. Leave a comment if you want to further the reflection on this topic, I'd love to hear from you. Thank you.